معلش انا هبدأ تاني بس عشان الريكوردينج. صباح الخير، انا اسمي رامز، assistant lecturer of cardiology هنا في عين شمس. This is a case presentation regarding a prosthetic mitral valve assessment by 2D transthoracic echo. Um, these are the objectives. Quickly, we will go over these items. Our case presentation today is for a 51-year-old male. He's hypertensive. He had a history of rheumatic heart disease. 27 years ago, he underwent mitral valve replacement, an aortic valve replacement, and tricuspid valve repair over severe tricuspid regurgitation for the rheumatic affection of these valves. He came presenting to us with dizziness and shortness of breath of 1 month duration. His ECG was an AF with complete heart block, for which the heart block has resolved into a slow AF eventually. His medical history was he was on warfarin 10 milligrams, digoxin, torsemide 50 milligrams, and metolazone 5 milligrams. This is the parasternal long axis for the patient using the transthoracic echo, the 2D transthoracic echo. This seems to be a normal function. We seem to appreciate that we have an aortic, prosthetic aortic valve, a prosthetic mitral valve. We have a dilated left atrium, and we have concentric LVH. These are all evident in this view. But as for the mobility of the mitral valve, we can appreciate that it is not functioning normally or doesn't seem to be moving normally, both occluders, and there is a radio opaque shadow at the site of the occluders themselves. This is the parasternal long axis cut for which the M mode was taken, showing that we have a dilated LV internal dimension of 58 millimeter, followed by the short axis for which we can appreciate that we have a normal function. Again, this is the left atrium as seen, cut by the M mode, showing a 66 millimeter diameter and another 61 millimeter using the 2D modality, both, of course, dilated left atrium as expected. This is the concentric LVH, 14 millimeters for the septum and less affecting the posterior wall, for which it was 13 millimeters. This is the LVOT diameter of 27 millimeters, which is essential for the measurements that will be taken over the aortic valve itself. This is the parasternal short axis view over the great vessels, showing severe tricuspid regurg into the right atrium. Here we can see that there's a dilated RV measuring 57 millimeters in diameter, for which the functions were assessed, showing a 13 millimeter TAPSE and a 6 centimeter per second S prime, denoting that we have an impaired dilated right side. This is the apical four-chamber view. A pulse Doppler was taken over the LVOT, and a continuous wave Doppler was taken over the aortic valve, showing that we have a mean pressure gradient of the aortic valve of 48 over a peak of 78. The LVOT trace was taken as well for the VTI that will be essential in the measurements to be taken further following the aortic valve and the mitral valve. It will be beneficial for both. Here we can appreciate the ejection time and the acceleration time of the aortic valve, for which it was 304, and the acceleration time was 95 milliseconds. This is followed by the measurements taken for the mitral valve. The peak E velocity was 2.72 meters per second. Of course, it is elevated or raised because our normal or the upper normal value for this is a 1.9. Here we have a 2.7. This is followed by the pressure half time, for which it was 88 milliseconds. This is not elevated. Our normal range is within 130 milliseconds or less. So this was 88. So far we have one parameter that seems to be abnormal. The mean pressure gradient trace was taken over it, and it showed that it was a 9 millimeters mercury. So we have an elevated mean pressure gradient. We have an elevated peak E velocity. However, the pressure half time seems to be within normal. This was a small mass measuring 5 by 9 millimeters seen related to the occluders of the mitral valve, for which we are assuming that this is causing the obstruction or the elevated gradients measured throughout the previous measurements. To assess a mechanical mitral prosthesis, and we have a high E velocity for which it was above 1.9 meters per second. Ours was 2.7. Our mean gradient was above 5, which was 9. And then the pressure half time was measured. Measuring the pressure half time, it showed that it was less than 130 millisecond. So as we were saying, the pressure half time was less than 130 milliseconds, which is also caused by the pathology seen related to the aortic stenosis. As we measured, the pressure gradient was 48 millimeters mercury as a mean. Eventually, you do the TVI ratio, which is expected to be less than 2.2. Ours was less than 2.2, and an effective orifice area was more than 1.2, suggesting of moderate patient prosthesis mismatch, and this will be further assessed during the aortic valve assessment. The DVI of both the aortic valve and the mitral valve were suggestive of significant stenosis. The effective orifice area as calculated was 1.28 centimeters per second, centimeter squared, I'm sorry, for the aortic valve, suggesting severe patient prosthesis mismatch. And that of the mitral was 2 centimeters squared, suggesting moderate. Okay, this was it. Okay, okay. The dis أقولها لحضرتك. Eventually, we have decided to do a better assessment by transesophageal echo for this patient. This is the two-chamber view. As we can appreciate, both occluders are not moving simultaneously, and there is a sluggishness in the motility of them, and we can suspect that there's a mass seen. Again, this is another view. This is the mass, yeah. There's an echogenic mass seen here. This is again another view to appreciate the motility of both occluders and to appreciate the presence of a very small mass as measured by the transthoracic echo. It was a 5 by 9 millimeter mass. Color flow mapping here in the three-chamber view shows aliasing across both valves, the mitral valve and the aortic valve. This is again the same view. Okay. Again, this is the three-chamber view here, the biplane view, without the color flow mapping, in order to assess properly the aortic valve, for which we have seen a mean pressure gradient of 48. We are excluding the presence of masses in relation to the aortic valve itself. This was the mass that was seen by the transesophageal echo. It was 4 by 3 millimeters. During the measurement by the transthoracic echo, it was a bit larger than this. However, this is a more accurate measurement of the pathology present. The patient's anticoagulation regimen was shifted immediately from oral, which was warfarin 10 milligrams, into IV. Plan B was to administer a thrombolytic therapy or undergo emergency surgical intervention in case of any hemodynamic deterioration of the patient. This was the case as we were planning on discussing a few points regarding the case itself.
صباح الخير، ازيكم جميعا. دي كانت المحاضرة بتاعتنا عن الميكانيكال مايترال فالف. كانت المحاضرة اللي قبل كده كانت على البروبر assessment of a prosthetic mechanical prosthesis across the aortic valve. كان في بس معلومة كان رامز بيقولها، كان حاططها في الأول عن السيفير patient prosthesis mismatch اللي على الاورتيك فالف، وكانت الرقم 1.2 بس دي مش indexed، هي الاندكس كانت احنا كنا مطلعينها 0.6 سنتيمتر سكوير بير متر سكوير. يعني لما الاريا طلعت انا عاملاها اندكس كانت 0.6 وكده indicating البيشنت بروثيسيس ماتش عشان ما كانتش مكتوبه في السلايدز. في اي حد كان عايز يسأل عن اي حاجه او عنده سؤال regarding اي point في الكيس؟ اه indexed. في نقطة كمان، فكرة الاعتماد على البريشر هاف تايم في وجود دبل فالفولر ليجن، عشان احنا البريشر هاف تايم بتاعنا كان 88 ملي سكند، واحنا كان عندنا increased gradient، ولما عملنا الايكو لقينا التران ثوراسيك ايكو لقينا، والترانس اوسوفيجيال كان فيه سمول ثرومبس مش عامله complete obstruction، لكن عامله مشكله في الميكانيكال اكتيفيتي بتاعه الاوكلودر. ليه البريشر هاف تايم هنا كان ما ينفعش نعتمد عليه؟ لان احنا عندنا another lesion اللي هو الاورتيك ستينوزس، فالاورتيك ستينوزس بيعلي ال في ان diastolic pressures، فالبريشرز بتبقى عاليه، فالتايم اللي بيتاخد عشان نيكولايز البريشر across الفالف across الميترال هيقل، فبالتالي البريشر هاف تايم هيقل. فالاعتماد على البريشر هاف تايم هنا for assessment of الميكانيكال فالفز مش هو اصح حاجه، عشان وجود another valve lesions. فليه في ال discrepancy ما بين الأرقام؟ عشان احنا عندنا حاجة تانية بتأثر علينا.
يعني البريشر اوف تايم ليه غير اللي قالته ساره، هو ليه ليميتيشنز كتيره قوي. ان العيان لما يكون تاكيكارديك، لما يكون في عنده مشكله في الفوليومز، ده كله هيأثر على البريشر اوف تايم. فالمفروض انك انت ما بتعتمدش على بارامتر واحد، بناخد اكتر من الميجرمنت.
بالظبط. تمام. في أي حاجة حد؟
Okay, this was our case. Eventually, we will take a very brief moment to discuss the parameters to be measured. This is a short, brief description of the types of the mitral valve, for which, of course, you know the mechanical and the bioprosthetic. There are different types of the mechanical. However, the most common is the bileaflet, which we see now. The stented tissue valves are valves, the bioprosthetic valves are of lower thrombogenicity in comparison to the mechanical valves. However, they are of faster degeneration in comparison. Our essential views, of course, the parasternal long and short, the apical 4 and the apical 2, and the subcostal view, which means the valve is assessed from at least 5 or 6 different views. Each has its own purpose. These are the cutoff values for which we are suspicious of the presence of any obstruction or pathology within the valve itself or the mechanical prosthesis itself. The peak velocity of less than 1.9, this is the normal value. The pressure of time of less than 130, the mean pressure gradient of less than 5, the effective orifice area of more than 2 centimeters square, and the DVI of less than 2.2. Always report. Okay, these as part of the assessment that's very important is for every Doppler parameter that you are taking, it should be under the guidance of the color flow mapping. This is number one. Number two, we always report on the heart rate as we measure gradients, because the gradients vary according to the heart rate. This previous patient, his heart rate was about 45 or 50 beats per minute, and this was because of the slow AF that eventually he was being treated for. And this was ideal for the measurement of the valvular lesions or the gradients that were present at this time. We compare these gradients to the baseline post-op echocardiography, and this is important in order to assess if there is any changes in these gradients or not. And these are the values with their normal range. Again, the mean pressure gradient, it's influenced by the heart rate, the rate of flow. This is the hyperdynamicity or the states of hyperdynamicity, such as anemia, fever, and pregnancy, and the valve size. We always correlate it to the heart rate. The DVI, the one that we were mentioning, yeah. The pressure half time, it's less reliable in prosthetic valves as it's influenced by the left atrial and the left ventricular compliance. When we have problems with both because of the valvular lesions that were present before the operations, these affect the compliance of both chambers, and this eventually results in the affection of the measurements we see. Pressure half time more than 200 milliseconds is suggestive of obstruction. However, our acceptable range is we go for a less than 130. The DVI is the VTI of the mitral valve over the VTI of the LVOT. Ours was usually within the normal range under 2.2. More than 2.5 is suggestive of obstruction. This obstruction can be caused by thrombus, appendix, and endocarditis, or a patient prosthesis mismatch. We have a small comparison here between thrombus and pannus. Thrombus is usually mobile, however, the pannus is fixed. The thrombus is of a softer echogenicity in comparison to the pannus, which is dense, looks more bright or calcific. The thrombus, if we are going to assess for a follow-up, it should improve when the patient's anticoagulated properly. However, the pannus will not show this response. Yes. As regards the effective orifice area, it applies the continuity equation where the flow across the LVOT is assumed to be the flow across the mitral valve. So we measure the LVOT diameter in the parasternal long axis, inner edge to inner edge at mid-systole. This will produce the cross-sectional area of the LVOT. The second step is measuring the LVOT VTI in the apical 5-chamber view by tracing the pulsed wave Doppler. Number 3 is we measure the mitral valve VTI in the apical 4-chamber using the continuous wave Doppler. So eventually, the effective orifice area of the mitral valve will be the cross-sectional area of the LVOT times the LVOT VTI divided by the mitral valve VTI. As regards the transvalvular regurgitation, there's a physiological that's acceptable and there's the pathological that's not. This is small, the other is large. This is usually symmetrical and central. However, the pathological is mostly eccentric. However, central could be possible as well. The physiological could be of a brief duration. However, the other should be holosystolic or more. This is of lower intensity. However, the density of the other jet, the pathological jet, is usually dense. As regards the PVL, we can assess the PVL severity as well. This could be done either in the long axis, the short axis, the apical 4 and the apical 2. However, we never rely on only one view or only one area for the assessment. It needs to be assessed properly, as this is a 3D structure that's being assessed by a 2D modality. The extent of these, the circumferential extent, this could be less than 10 to 30 is moderate. Below 10 is mild, above 30 is severe. The number of jets as well, and if there is presence of hemolysis as assessed by the patient's CBC. Thank you.
شكرا ليكم جميعا. في أي حد كان عنده سؤال؟ شكرا.